the name, the NECA, as it stands for National Evidence-Based Health Care Collaborating Agent, has been serving as a central pillar in Korea's health technology assessment landscape since 2009. As a government-funded but independent nonprofit organization or institution, our work aligns closely with national health policy, the goals in Korea, including rational expansion of universal health coverage and optimization of health resource use. There can be quite few in number of key elements that make NECA's deliberative process unique compared to other international approaches. I could list four in my mind. First is public involvement through the PIN system. We call it Public Involvement Network. We have up to 1,000 volunteers from citizen representative to be involved for the assessment during all the process. And with this public network, we work together selecting topics for discussion and social values of technologies. And through evaluation and assessment, we release information statement or leaflet to support rational and informed decision making. Secondly, comprehensive and systemic deliberation system. Our HTR process involves structured three-level deliberation system. First is subcommittee composed of field-specific experts and NECA researchers to co-development, evaluation, protocol, and reviews the evidence. And robust evaluation framework would be the next one. Our assessment go beyond clinical effectiveness and safety. We also look at economic aspects and social dimensions. We integrate multiple forms of evidence, including real-world data. Lastly, but not surely leastly, I could list the fourth as a strong transparency. All committee discussions, including dissenting views, those who are against, are formally documented, and conflict of interest disclosure are mandatory for all participants, and final recommendations are published and publicly accessible at any time. This ensures high degree of accountability and public trust. So, put it together, these features make NECA's deliberate process both methodologically rigorous and socially responsive, which we believe set it apart internationally. Thank you. In Korea, we have faced several and many challenges. The one would be balancing technical complexity with the inclusiveness. And second would be managing different priorities and interest. And third, the keeping participants engaged over time. So some topics are highly specialized. We have to work to ensure that lay participants, including patients and citizens, can still meaningfully engage. And stakeholders often have different priorities of interest. In some cases, for instance, for technologies widely used in primary care may not be interested by the third or tertiary, the hospital physicians. To address these challenges, NECA has focused on enhancing accessibility. We offer plain language summaries to help non-experts, including patients and the public. The second, transparency. We publish committee reports with the structures, with reasoning behind our recommendation through the HTR report. Third, the conflict of management, interest management. All committee members must declare any potential conflicts, and we manage those openly. And last, stepwise deliberation. As I've mentioned, we have three, the deliberation process from subcommittees to and the last is the committees to decide, and in between we also have those group that assess. They're composed of external the reviewers. So we use subcommittees to review the key issues in depth before making final decisions, which allows for reflection and better consensus. All of this helps to build trust, ensure accountability, and support shared decision making. Thank you. I believe Korea's the experience may offer several takeaways to other international families. The first, HTR should cover the full life cycle of technologies. It is not enough to assess technologies only at the time of adoption or approval for the clinical use. The periodic reassessment ensures continued values and safety, especially as evidence evolves and accumulates. Korea's HTR program operated without a specific law in before, but strong political support and alignment with broader health goals made it possible to scale up. During the last 6 years since its establishment, and for the last 6 years I've been in chair of the committee. Over the time, luckily, as the value of reassessment become widely recognized across the stakeholders, this foundation enabled us to move forward fully legal institutionalization, now set to take effect in September 2025 and will be covered by the medical law. The second, institutional independence matters. NECA doesn't make reimbursement decision directly. It is up to the HERA and NHIS, which helps us maintain and remain the trusted and objective evidence provider. Third and last, raising social awareness and acceptance of HTR. Introducing reassessment may be perceived as an added regulatory burden to every physician. It is therefore crucial to build public and professional consensus that HTR is not about restriction or regulation, but about improving the healthcare system and its integrity. By identifying and reducing the use of low-value technologies while encouraging the adoption of high-value ones, HTR serves as a necessary tool for maintaining sustainability and quality in healthcare. In summary, I recommend building it in deliberation, public involvement, and flexibility to use real-world evidence. These features really help align HTR with real-life policy and clinical needs. Thank you very much.